I really think it's an important issue, very important issue, because one of the big criticisms of intervention research is that it's atheoretical, that a lot of people just kind of go fly by the seat of their pants. And I really think that's a problem, and it's really a problem because on a number of different levels. First of all, if you don't have a good theory to base what you're doing, you don't have a strategy, and you don't have an approach. You don't have a good reason for what you're doing. Second, it's a big problem because you're really not adding to the literature in any meaningful way, because you're not testing in any way, showing that the theory has validity and works in the real world, or refining or advancing knowledge. Third, it's a problem for you because it's going to be very difficult for you to get your work published if it's not theoretically grounded, and more funding agencies are requesting theoretical grounding for your work as well. So on a number of different levels, I think the most important one is that it increases the vitality of your intervention and it gives you strategy, gives you direction. Typically I use a variety of different theories because I find that it's very rare that there's one theory that covers the entire range. Many of them are communication-based theories, but then sometimes based on the kind of work I do, I'll find theories from other disciplines. For example, lately I've been doing some work in the area of artificial intelligence, and designing strategic, interactive health information systems that are relationally competent, that develop the ability to mirror emotion and to interact in playful ways with people that are very different from typical human-computer interfaces. And so I use some different theories from computer science that I have not used before. In the work that I've been doing with the Korean American immigrants, I use theories about immigration and health issues that are not really out of our discipline, but most of the ones are generally information science, communication, psychology, public health theories. And when I was talking to this group, JBS International, probably about 3 or 4 months ago, they wanted to know how they could increase the robustness of their interventions by having a stronger theory base. And so I was focusing primarily on behavior change theory. And behavior change is probably the primary focus of most health communication interventions. Sometimes it's just increasing awareness and knowledge, but I think that ultimately the goal is always to try to change behavior to improve health outcomes. So let's see what I got here. Challenges to influencing health behavior change. Health behaviors are very difficult to change because they're entrenched. That people behave the way they do, not just because they decided to do it that day, but because they've been learning their entire life and they get continuous, unanimous reinforcement from all of their cultural mates that this is the normative way to behave. So to get people to change, central normative behavior is basically asking them to give up their entire, tradition and culture, which is very difficult to do. A lot of the behaviors that we engage in are really not reasoned behaviors. They're not active choices we make, but they're basically things that we just think are the right thing to do. We learn them, they're routine. Health behaviors in particular are hard to change because a lot of them are very intimate, personal behaviors, like your grooming rituals and your cleaning rituals and your eating rituals and your sexual behaviors, and these are not things that are usually up for grabs. It's not like that you want to discuss this with anybody. It's very personal, and it's pretty odd for people to ask you to change how you live your life. Consumers are basically pretty satisfied with the current health behavior because they've grown to know them and love them and be comfortable with them. And it's kind of like there's this theory called non-conscious ideology. I don't know if you're familiar with it. It was something that Darrell and Sandra Bem, they're pretty famous psychologists, came up with. They talked about it in terms of sexism initially, is that a non-conscious ideology was the assumption that this was men's work, this was women's work, this is how men behave, this is how women behave, without ever critically evaluating why we came up with those ideas or what it was that made us think that this was the expectation. And it's the same thing with health behaviors, that it's usually beyond the level of recognition. It's a non-conscious ideology about how we behave. And because of that, people just assume this is the right thing to do. In fact, this is probably the factor in culture that leads to ethnocentric behavior, is that people just assume my way is the right way and your way is the wrong way. And if I'm telling somebody to do things my way, it's really rubbing them the wrong way. It's like me telling them they are bad, they are wrong, their culture's bad, all the people they love and respect are bad, their mom, their dad, everybody in their life is wrong. And so it's a very difficult thing to do. There's a low awareness of problems with current behaviors. There's a strong belief in the efficacy of those behaviors. When I was working in Malaysia with the Malay women with breast cancer, they really believed that the recommendations by the BOMOs to chant and to burn incense was an effective way to deal with breast cancer. And I mind telling them that really there's no connection between incense and chanting and breast cancer. Didn't really defray their belief, because they had strong, long-term belief and confidence in the BOMOs, and knew the BOMOs would not hurt them, they would help them. And so eventually, we kept trying to change that system and realized, maybe we better change our way of thinking, because this is an ingrained cultural issue. And so we ended up getting the BOMOs to start introducing different strategies for the women, and then they listened. So it was a very good lesson for us about the dealing with health beliefs and behaviors. Resistance to accepting behavioral recommendations, we talked about already. People have a very low personal efficacy, often for changing, especially entrenched behaviors. Like most people who smoke cigarettes would prefer not to smoke cigarettes, at least in the U.S. The vast majority of people who are smokers tell us they would love to quit, but they just don't think they can. Or they don't think they can maintain quitting. We hear the story that people say, yeah, I can quit, I've done it 1,000 times. But they just can't sustain it over time. Lack of support, especially local support. Thank you so much for sort of changing behavior. And we know that within normative social systems, that local support is the most powerful. Your mates, your peers, your family members, those are the people who need to encourage you. And in fact, this is a really powerful recommendation for making social changes, is to engage family members. Yesterday when we were talking, Mrs. Mohan came in and we were talking about the current project with the Women's Heart. And one of the things that I suggested was that maybe we should shift this from an individual based thing to a more family based. How do we get family members more involved? Because a lot of what these women are going to be doing and living their lives and dealing with the repercussions of heart disease have a lot to do with family support and encouragement, especially social support. Cultural reinforcement to maintain current behaviors needs to be encouraged. It can be done on an individual level, is what I was just saying. And then there's tremendous amount of recidivism. There's a lot of people that are very excited. They moved the needle, they made a change. But typically it's because it's just then and now and people are watching. So for example, like they do a smoking cessation, and at the end of the smoking cessation program, they ask people whether they were able to quit. They say yes. And they say, well, we've got 90% success rate. But 2 weeks later, go back to these people, they're all smoking again. It didn't really maintain that behavior over time. So you've got to figure out how do you sustain the intervention, and how do you provide continuous reinforcement for appropriate behavior. Theories and models. There are three major categories, at least there's three that I came up with. The trilogy is a really common theme in my work. I think that's as far as my mind will go. I can only think of three major things. So I've got three approaches here. The individual cognitive models, and these are the most popular by far, and they're the simplest. And they're the ones that are basically say the individual needs to be changed. And that's what I was, that's what I was saying to Mohan, was that was the approach they were taking. It's a good approach because people do have responsibility for their behavior. It's a bad approach because it's difficult to maintain that over time, especially when you're getting divergent reinforcement for normative behaviors from everybody else you know, love, and respect. And so if you don't change the social system, and the psychotherapists have learned that. That was one of the things that Václavik, Bevan, and Jackson, that was a big group that did Pragmatics. of human communication. Are you familiar with that book? It was like a landmark book in the 1960s that started to say that communication was the center of human behavior. And they were the ones that came up with messages and meanings, and communication is irreversible, and communication is everywhere. A lot of the basic interpersonal theories came out of their work. And they were talking about how if you can't change the social system for behavior, it's very difficult to change an individual. So they started doing therapy with families, everybody involved, so they would change the system rather than just working one-on-one. It was really a very revolutionary thing, because all of psychotherapy, all the Freudian, Adler, all of them based on one-on-one with the individual. And they took a more systemic approach. And then they had a number of people that built on their work, Jürgen Reusch, Virginia Satir, a whole range of people, and then the communication field picked up on it, and I think it's been very powerful. So that's why I want to move to the next level, which are social theories and models, which engage the larger social system. And then the last one adds, not only the people and their social system, but the place. That if you don't recognize the constraints of society, available resources, geography, buildings, income, regulation, you're really missing the boat. And sometimes those social constraints, those structural constraints, are far more powerful than anything you can do. In fact, I think that probably in the U.S. the thing that was most instrumental in reducing cigarette use was legislation that said you can't smoke here. It's illegal to do that. You made high taxes on cigarettes. These are all structural constraints. And so I think we need to look at some of those environmental models. Typically what I do is I use a combination of those models. They all have their own strengths, they all have their own weaknesses, but I think combined they provide some really neat ways of thinking about human behavior and intervention. So let me talk about what these are. These theories should be viewed as a continuum moving from strictly individually centered to more macro level, structurally and environmentally focused models of health behavior change. All right, health belief model. This is the old chestnut from public health. It's been around for a long time. I think Becker was the guy who came up with this. It's a very nice model that basically says people will take a health-related action if they feel the negative health condition can be avoided, has a positive expectation that the recommended action avoids the negative health condition, and believes he or she can successfully take the recommended health action. So basically what you want to do is you want to change your beliefs. Most of the time people don't believe these things. They don't believe that they can avoid the situation, that this is the way things are. They don't have a positive expectation that the recommended action will help them in any possible way, and they don't believe really they can successfully do this. And so you're fighting against this, you're changing their belief, saying this is a good thing to do, this can be done, you can do it, it will make a difference, you'll feel good. It's a very encouraging model because you're telling them that they can do it. Here's a figure that shows how it works. And you can see that this is, really ties into what I was talking about yesterday with audience analysis, is that you want to find out all these things. These are things that you want to look at. What are the socio-demographic factors? All the prisoner of war information, rank, name, rank, serial number, where they live, who they are, what their gender is, what their ethnicity is. These are all the background factors. What their psychological set is, beliefs, values, attitudes, expectations, perceived benefits, perceived risks, perceived barriers, what are the threats that they see, and then based on that information you come up with a plan of action through the use of media, personal influence, reminders to shift those beliefs and to encourage engaging in behavior. It's a good model, it works pretty well. But the big problem is that it's an individually focused model that doesn't take in some of the larger constraints. And so in many ways it's kind of simplistic, is that we think that, your behavior is personally, solely personally influenced, that it's not really focused on encouragement by others, It's not really encouraged by availability of resources, by regulation, by other factors, and we know that behavior is strongly influenced by all those factors. So in an ideal world, where you didn't have all those other constraints and you could do exactly what you wanted to do, this would be a great model. Unfortunately, none of us live in that ideal world. We have lots of other factors that constrain what we do and recommend courses of action to us. There's the self-efficacy model, and the self-advocacy model is based on the work of Bandura. It's based on a number of different factors: perceived competence, perceived difficulty, basically how well you can accomplish the goal. It's a combination of how competent you are and how difficult the problem is. It's kind of like a balance ratio. So when you're trying to change behavior, you've got to figure out how hard is it going to be for people to change this behavior, and how confident are they that they can actually achieve it. Most of the time in health behavior change, the problem is great and the efficacy is low. And that's the reason why people behave that way. If it was easy, they would do it themselves. You say to people, okay, I want you to change your exercise behavior. I want you, from now on, you're doing 10 miles a day. And they say, oh yeah, oh sure. Thanks a lot. And then they get in their car and they drive away. So it's kind of like a balance model of what you're asking and what they can do, and what is their expectancy of success. So when you're communicating, you're trying to encourage people. You try to show them that these things can be done. Typically, you do a lot of modeling, showing people like them have been able to do this in the past, and then you can improve their expectancy of success. And then you can reinforce that information over time through media and communication, through interpersonal communication. So then through that reinforcement, you actually change their behavior. Sometimes this is called the social cognitive learning theory. The premise is that new behaviors are learned either by modeling the behavior of others or by direct experience. Social learning theory focuses on the important roles played by vicarious, symbolic, self-regulatory processes in psychological functioning. It looks at human behavior as a continuous interaction between cognitive, behavioral, and environmental determinants. Mostly what it is trying to get people to change the way they think about themselves and their situation, and encouraging them to have a sense of confidence that they can accomplish their goals. Essential tenets of social cognitive theory are self-efficacy, outcome expectations. We'll go to the next one. So you want to try to improve self-efficacy and change your outcome expectations through communication interventions. And typically the best ones tend to be modeling behaviors over others. So providing stories, providing examples, providing encouragement from relevant others. This theory led later on to the use of edutainment as an intervention, because it was a great way of promoting that modeling behavior. We'll talk about edutainment later on as another approach. So the theory of reason action, this is anybody who came out of the Penn program. Yeah, some Asians get dropped out of this. It became the fishbone model. Marty kind of claimed it. First was Asian and fishbone, then it was fishbone and Asian, then it just became fishbone. But everybody out of Penn uses this model. It's based on the assumption that human beings are rational and make systematic use of the information available to them.
Maybe not used to smoke.
He didn't have the expectancy that he was going to change. People consider the implications of their actions in a given context at a given time before they decide to engage or not engage in given behavior. And the most actions of social elements are under volitional control. This seems like a very ideal model to me. And a lot of times people don't have volitional control. People don't have, they may want to do things. There's so many things that people, if you look at the New Year's resolutions, every year people have New Year's resolution, they're going to lose 20 pounds, they're going to go to the gym. The gyms love this because people will join like crazy. They oversell like by 250% because they know that after 2 weeks, none of those people are going to go anymore.
They just sell the annual membership. Yeah,
Exactly.
annual membership.
Theory of recent action specifically focuses on the role of personal intention in determining whether behavior will occur. A person's intention is a function of two basic determinants: attitude towards the behavior and subjective norms of social influence. The theory of normative behavior was reason action was expanded into a larger model because of a lot of criticism that this was a little bit ideal, it was a little bit superficial. People really, so they started to figure out that there's a bunch of things they can put together, and this is a more powerful model. It's also a much more complicated model to implement because there's so many different moving pieces involved. So I said, okay, wait a second, it's not only intention, it's not only attitude, it's all these background influences. So now we've got to look at past behavior, demographics and culture, attitudes, stereotypes, personality, moods, emotions, individual differences, intervention, exposure, and all these factors are the influential ones. And based on this, you can start influencing beliefs and outcomes, normative beliefs and control beliefs, which change attitudes, norms, and self-efficacy. Eventually, this changes their intention, and then you have to have environmental factors that will encourage and build skills and abilities, and then it leads to change in behavior. But it's a long, honking process to do that. Fear appeals. We talked about fear appeals yesterday. You know, the bad thing about fear appeals is they really work. I don't like fear appeals very much because I don't think it's very nice to scare people. And I think it's kind of mean. It's mean-spirited. But, you know, but because they work, people use them. But it only works for a little while. And it only really works when people are totally unaware of the problem. It's really, really good at raising awareness because it scares you. And it's memorable because it's painful. You know, there's this old adage that we learn a lot more from pain than we do from pleasure. And so, you know, if you really want to learn a lot, you got to live a thorny life. You know, I think this is kind of the Buddhist philosophy of the monks. You know, walking on fire, living an uncomfortable life, having no possessions, begging for food. It's because they want enlightenment, they want to learn, and they're willing to, you know, live a life of deprivation to achieve that. And I think that, you know, to a certain extent, that's part of like discipline and, you know, forcing yourself to focus on things. But I don't think it's a very nice way to force people to learn. And what ends up happening is that we have a lot of defense mechanisms that we've built over time, psychological defense mechanisms and social defense mechanisms, to not suffer. Because not many of us, unless you're a martyr, most of us don't want to suffer. And so after a while, you know, people block out those fear appeals. They habituate them because it's not very comfortable, and so they have a kind of a limited, utility, and and you end up getting angry at the people who are being mean to you. You know, there's only so many times you can shock somebody before they say cut it out. If you want somebody to change their behavior, and every time they do something wrong and you smack their hand, they start getting pretty angry at you for doing that and they stop focusing on the issue. So messages are designed to scare people, describing terrible things that will happen to them if they not do what the message recommends. And we often do that by showing really vivid threats, danger or harm that exists in the environment, perceived susceptibility, how susceptible are you to these threats, perceived severity, how bad is it going to really hurt you a lot. And then you want to influence their appraisal of efficacy, which means that they can actually do something about it. This was part of the work that Ken Whitty introduced, is that if you want fear appeals to work, you've got to give people a way out. You're building pressure, you're building tension, and if you can't reduce that tension, then people just will stop thinking about it because of self-preservation. But if they have something they can do, and it's easy to do, then they'll try and to accomplish their goal.
One of the major problems before in Singapore is that most of the campaigns, using the fear appeals to disseminate the message. But then that links to another question, because I saw some changes, along the years. Nowadays, they don't use that strong fear-arousing messages anymore because probably they realize that they would generate some kind of boomerang effect. Not only the boomerang effects, or ignorance, or even their unfavorable attitude toward the health agency, mainly the health promotion board, because it's just like why the government always want to push us and then scare us in this way, right? But the other issue related to this is that when I discuss with some of the students about the government's use of the fear pills, their response is that, oh, we don't think that's scary, mainly because they think that kind of message design doesn't really arouse any kind of fear. So I think for the perceived severity and perceived vulnerability, that also links to what extent that message design really can trigger fear. Because otherwise, our students just say, we think that's funny.
Well, because they hear it so much, what happens is it's kind of it wears off over time. They become inoculated.
Yeah. I think they couldn't see it anymore, like the graphic, photos on the cigarette packs. Now they just couldn't.
It's like the old children's story of crying wolf, The first time you cry wolf, everybody closes the doors, locks the door. No wolf shows up. Maybe the next time they're a little bit, after a while they say, go away, there's no wolf.
Because the first time when I came to Singapore, I remember the first few years I can feel, those kind of, campaigns using, fear appeals everywhere. And then I just feel like, okay, this environment is really, really, very pushing in a way that, okay, you have to be aware of this, you have to be aware of that. And then gradually now, I don't feel anything either because they changed the campaign strategy, or, I'm also, getting used to it, and then I couldn't feel it anymore.
Yeah, and I just don't think it's a nice way of educating and influencing people. It's not a collaborative strategy. It's a one-up strategy. Whoever is initiating the fear appeal is in the power position. I think it's much better to try and, encourage people, support them, build their capacity, work with them. I think that works better in the long term. So I think a lot of the effects, the positive effects of fear appeals are very short-lived. They don't have a, ability to maintain over time because people don't want to be continually hurt.
And also it's generally some effect, right? Because most of the campaigns are run by government agencies. So then gradually citizens would have this kind of feeling that, oh, okay, so this is the way that the government communicate with the citizens. Actually that generates even, negative and long-term effects on the relationship between the government and citizens. And actually that's something that we observe in the long time. So
and I'm not sure what the relationship is here, but in the U.S. there's tremendous lack of trust in the government officials. And maybe this is part of that. They don't feel that the officials are looking out for them, that they're taking advantage of them.
In Singapore, I would say it's like a love and hate relationship because you can see that government is very efficient in a way of taking care of the citizens, providing all the infrastructure. The government is very effective and efficient in that way, right? But on the other hand, because the government has such strong control of everything, and sometimes especially for the younger generation, they will just feel like, okay, we are not your children, so you shouldn't use this kind of very authoritative way to teach the citizens, to educate the citizens and saying, okay, this is the right way for you to do things. So that links to other issues, and then the dynamics between government and citizens that way. But the health sector actually reflects that kind of relationship between government and citizens in a similar way.
So, I think that there's a place for fear appeals. At one point I was basically saying, let's do a moratorium, no more fear appeals. But I really thought that because I think that there's a real good function for it. I just think it has to be used at the right time, the right place, and also for a limited duration. But I think if you continue it over time, it's going to cause problems. And if you use it as your default strategy, you end up losing credibility and you're not going to have the desired effect.
And also I think we want to nuance fear appeals. There's some of the things on the cigarette packets, for instance, that's more like disgusting images, and people might not even want to see them, and that might take them away from engaging with the message.
Right. In fact, in the U.S., the tobacco industry came up with a strategy of giving out free cigarette pack covers. They're very pretty. They're crochet. They have colors. They have pictures. And so if you don't want to see, just slip your cigarettes into this little pack. And they give them out for free. They're very nice. So that way it's easy for them to just block it out. So you want to try to improve response efficacy, self-efficacy. Possible outcomes, there's 3 responses that you can have to a fear appeal message. No response, which happens a lot. Fear control, which is you minimize your fear, or then danger control, where you minimize the outcome. Here's the extended parallel process model that Whitty came up with, that tries to be a little bit more sophisticated about the use of fear appeals. So if you want to use fear appeals well, you've got to try to balance protective motivation and defensive motivation. If the people are more defensive, they're not going to respond well to your outcome. But if they move more towards protection, and if they have a higher efficacy, they'll actually achieve what they need to do. So if you want fear appeals to work, you need to try and build a sense of efficacy so that the fear can be controlled by adaptive changes. If they don't feel that they can control the fear, then they get defensive. They want to avoid it. They're not going to be able to deal with it. So you want to move them towards danger control rather than fear control. Fear control is basically blocking out the message. Danger control is dealing with the problem. Here's the application of the EPPM model. Incoming message, perceived susceptibility, am I at risk for this health problem? Yes, then you want to move to perceived severity. No, then they don't really have to deal with the problem. Is this health problem serious? If it's yes, then they move down to the next step. No, then they're out of the loop. So you've got to demonstrate along the way that they are at risk, that this is a serious problem. And then it becomes, do I believe the recommended action will actually avert the danger, helping them have danger control? If you don't provide that information, and many fear appeals, believe it or not, don't do that, then you're wasting the time. They basically go to a fear control response. But if they do know that there's something they can do, and they have self-efficacy that they can actually do it, and then it moves them to a danger control, where they're going to actually do something to try to achieve their goals. And so this is a kind of a nice flow chart to figure out, what are you doing with your campaign? Are you actually achieving these goals? Are you helping them recognize the danger, the susceptibility, and their ability to deal with the problem? Here's an example from cardiovascular. Low threat condition. 20 minutes of cardiovascular exercise 4 times a week will reduce the risk of heart disease. Perceived threat. This low perceived threat. Heart disease doesn't run in my family. Many people with heart disease live normal lives. I don't care if this is not important for me. No threat perceived, no response. Okay? So if you want to try to do this, you need to come up with high threat. But if this situation you have low efficacy, that's not going to work either. This is the typical fear appeal situation. High threat. Okay? This is what we want you to do. This heart disease runs in my family, can be fatal. But I don't think there's much I can do about it. I don't have the time. I don't want to do this. It's a pain in the neck. And so you move to a defense motivation. You're trying to control the fear. Maladaptive changes, you're not going to work it. So here you want to have the situation, this is the ideal, high threat also, but high efficacy. Same issue. This is serious. I can do it. I can make the time. I want to protect myself. I'm going to control danger. I'm going to have adaptive changes. Our Transtheoretical Model, this is one we've talked about quite a bit. It's really the big one, I think, in public health. In many ways, it's similar to diffusion of innovations, because where diffusion looks at your willingness to adopt innovations, this looks at your willingness to make changes. Transtheoretical Model uses stages of change to integrate processes and principles of change from across major theories. It was labeled transtheoretical because concepts came from different theories of human behavior used to change people. uses comparative analysis of leading theories of psychotherapy and behavioral change so that they can come up with a series of steps towards change. So here are the stages, or more. Prochaska, actually I know Prochaska pretty well. I know Di Clementi too. They don't work together anymore. I know what happened to them. Prochaska is working primarily in, he's had his greatest success in tobacco control. They've also worked with alcohol and other diseases, but it's been best at. Di Clementi has been working a lot in AIDS prevention. I've actually been on a couple of grants with him. So they posit 6 stages. Pre-contemplation, it's kind of like thinking about it, but it's not really an agenda. Contemplation, it's on your agenda, but you're not doing anything. Preparation, you're starting to mobilize. Action, you're actually involved. Maintenance, you're actually, maintaining it over time. And then the last one, this is not a good one, is that you weren't able to maintain your relapse, which means that you try to move them back through the stages again. Core constructs, there's a temporal dimension of moving people over time through different changes. There's covert and overt activities people use to progress through the changes, obvious things and personal issues. Decisional balance, weighing pros and cons of changing behavior, which means that you need to provide them with good information so they can make good decisions. Building self-efficacy as in the other ones. So here's the picture of the model. The temporal dimension, it's over time. Behavioral intention, where are you on the 5-point scale? You left out the relapse here. And then how that's going to influence your behavior. So if you can move people in this direction, then you're going to be able to change your behavior over time. The nice thing about this model is that it's a evolutionary model. It's a longitudinal model. It doesn't think that you're going to make a change right away. It recognizes that you need to reinforce behavior over time. It also builds on self-efficacy, where you build confidence in your ability to make a change. It also comes to people where they're at rather than using a one-size-fits-all approach.
You talked about covert and overt activities.
Well, basically those are the internal issues, the psychological or the covert, and the overt are the actual messages that you provide to try and encourage them. So that you've got to make sure that you are providing actual overt activities that will change their internal processes. The Elaboration Likelihood Model, we mentioned this yesterday, I couldn't remember the name at the time, but I was talking about your ability to process information and your thinking about it. Holds that there are 2 routes to persuasion, a central route and a peripheral route. The central route is generally the better one. The presence or absence of elaboration or thinking about the ideas presented is critical. So the central route to persuasion is that attitude change stems from purposeful evaluation, logic, or elaboration. So you really want, and in many ways this fits back with the stages of change, because you want to get things on people's agenda, you want them thinking about it. It actually fits also with the Fishman and Agent model too, because you're getting them to have intentions to make changes. Create more enduring attitudes related to behavioral intention, works with consumers involved and willing and able to elaborate. The peripheral route to persuasion is one where driven by attractiveness of expertise, a number of arguments, happens relatively quickly, depends on the mood and emotional state of the consumer. It doesn't tend to work quite as well, but it's based on reinforcement over time. So here's the persuasion attempt. The message, you're looking at audience factors, high motivation and ability to think about the message, deep processing based on quality of the message arguments, lasting change that resists fading and counterattacks. That's the elaboration model. The low motivation is the peripheral approach, or low motivation or ability to think about the message, supporting processing, superficial processing focused on surface features such as communicator's attractiveness, a number of arguments, a temporary change that is susceptible to fading and counterattacks. So basically with the implication here is that you want to try and provide enough substance within the campaign or the intervention to get people thinking and to really processing and changing their attitudes. Unfortunately, a lot of the interventions are very superficial, and this is one of the problems with the fear appeal. is that it captures attention, it gets people involved, but it doesn't really get them thinking over time, especially because they're also always avoiding the fear.
Yeah, I think that your other presentation from previous week where we talked about when you're trying to segment the audience and you want to also know how involved they are with health behaviors already, and the ones who are already highly motivated and highly involved and health conscious are likely to engage with more central route messages.
Especially if you provide them with
If you give them that
information.
information.
Exactly.
But then those who don't think this is relevant to them, but you still want to reach out to them, then the way to bring them in might be the peripheral route, using some attractive.
At least initially, but it's not going to do the job. I think what you need to do is you need to move them along the stages until they get to the point where they are interested and they will pay attention.
So maybe in the pre-contemplation stage, we could use more the peripheral route.
Right, and that's why fear appeals are good when there's low awareness.
When there's low awareness.
Because it's not a central route, but it's peripheral, but it's a dramatic one.
Yes.
And it raises awareness. Hopefully that's the the point. You've got a teachable moment there.
Right.
Where then you can get people more involved and then give them more information. But it's amazing how many health promotion campaigns are very shallow in terms of depth of information. Like we talked about the dengue thing in the bus. It scared them, but it doesn't really give you any information about what you do, how you do it, what's going on, where you're at risk. It was just kind of a very superficial, peripheral way of trying to deal with the problem. And because of that, I doubt that it really changed many behaviors. It may have raised awareness for the moment, but by the time people got off the bus, they forgot about it.
Or I remember the image, but I really don't know the solution, right? So in that case, if we use which is EPP and everything, it's okay, they can successfully raise the fear, but then the efficacy part is missing.
So it becomes fear control rather than damage control anyway, because But I think that there's also the other issue of there are other campaigns where the information is so in depth and. For instance, in the medicines that we eat, the pamphlets that come with it are so very detailed, but they're not attractive.
Right.
They're not, in that sense, then we want to also have some amount of attractiveness and engaging, interesting materials.
And also matching the level of the information to the literacy level.
Right.
So that people can understand. In fact, we talked a little bit about that yesterday, and I'm going to talk a little bit more today when we talk about message design and strategies. So it's not just providing the information, but providing the information in a way that's attractive, interesting, understandable, usable, culturally appropriate.
So we seem to have like two different extremes. On one extreme you have such detailed information provided in a very unattractive way, and on the other extreme you have just very superficial peripheral information, which does not give you any solutions of how to deal with that problem.
We were talking the other day about the package inserts on the medications. They have tremendously detailed information, but it's in language that nobody can understand. It's in typeface you can't read. It's just not a very engaging way of presenting that information. Plus, there's no way of matching that information to the level of involvement of the audience. That's why I like a more interactive approach, a more tailored strategy of trying to give people the information that they need, that they want, when they need it, and want to then move them along over time. I think we need to engage in more of a relationship with people. And that's why in an evolutionary longitudinal approach to behavior change, I think works much better. We'll get to some of those ideas in a little bit. So here now we're going to move one step up from the individual to the more social theories and models. Motivations for health behavior are complicated, unclear, may not be thought through in advance. Social norms, religious criteria, gender, power relations, and many other cultural factors infuse meaning into behavior, enabling positive or negative changes. Main difference between individual and social models is that the latter aims at changes at the community level as opposed to at the individual level. And so I've been trying to utilize more systemic approaches to behavior change and intervention that involve communities. That's why I really like working within the family. I think that the family is probably the most powerful center for health information, health education, and health care. You know, we tend to think that healthcare is done in clinics and hospitals, but it's really done at home. And moms are like the key chief person in most families. They're the ones that do it all. And for those people who don't have moms, somebody else has to take on that mom role. And sometimes they do and sometimes they don't. Diffusion of innovation theory is one that I use a lot. It's a model that looks at the community. People's exposure to a new idea which takes place within a social network or through the media will determine the rate at which various people adopt that behavior. The theory says that people are most likely to adopt new behaviors based on favorable evaluations of the idea communicated to them by other members who they respect, admire, and will listen to. So you're seeing that the social system and the personal networks are powerful here. So here are the stages of adoption. You notice how similar this is in many ways to the stages of change: awareness, interest, evaluation, trial, adoption. Awareness is individuals exposed to the innovation but lacks complete information. An individual becomes interested in the idea, seeks additional information. Individual starts to evaluate the innovation and anticipate future uses of the information. People start to try out the information, and then eventually they adopt the information and utilize it. And so the goal here is to try to provide social support and encouragement for people to move through to adoption. And I think one of the critical factors is evaluating where people are to start with. Here's the diffusion of innovation model. What are the characteristics of the people that you want to change? What are the social characteristics? What are the personality characteristics? Whether there's a perceived need for innovation. Based on that information, you can try and figure out what their knowledge level is, how you can persuade them, how you can influence decisions, how can you confirm that they're actually engaging in those behaviors. And you need to do that by not only giving them information, but by getting the social system to support those changes through social norms, tolerance of deviancy, seeing people are willing to accept new ideas, and integrating that into the communication system. Based on these factors, as you move forward, people will either adopt or reject the idea. If they reject it, you need to move through and find other ways of providing support for encouraging adoption of behavior over time. The implication here is that you need to get the community to encourage people to engage in behaviors. You need to find people who are early adopters, who are attractive, who are good models that will be ones that will show people that this is the right way to behave, that this is a good thing to do, and this can be done. Social network theory. This is basically the sociometric analysis of interconnected webs of influence. It's often done with network analysis. Social network theory looks at social behavior not as an individual phenomenon, but through relationships. Appreciates, for example, I've been doing a lot of work with this with HIV. HIV risk behavior, like many other health behaviors, directly involves two or more people. The work that I've been doing over the last 5 or 6 years with the National Minority AIDS Council has been trying to build networks of support for encouraging AIDS prevention and support within at-risk communities in large urban areas around the United States, particularly for African American and Latino populations, where the risk of AIDS infection is much higher than for the Anglo population. Although the intricacies of relations and communication within the couple, the smallest unit, the dyad of network, is critical to the understanding of health behavior. The scope and character of one's broader social network, those who serve as reference people who sanction behavior, are key to comprehending individual risk behavior. In other words, social norms are powerful and need to be understood at the level of the social network. So one of the things that we try to do as change agents, as interventionists, is to shift social norms. That's easy to say, it's difficult to do. The way you need to do that is by finding the major influences within social networks, encourage them, or find them, those that are already believe in what you're doing, and engage them as your advocates within that social system. So what we had done within the AIDS program, is, and I think I talked a little bit about this earlier, is that we identified community liaisons, people who are credible, well-known, well-liked people in communities who felt strongly about serving their community and stopping the spread of AIDS, provided them with information and support, and encouraged them to have meetings, formal and informal, with friends and colleagues to talk about these issues and share information. And then when they were meeting with them, they would encourage any and all of those people that they met with to also engage as facilitators, liaisons within their own personal networks. But rather than doing this kind of in a cold way, like cold calling, we had them doing it within their own friendship networks, within their own families, at workplaces, at social gatherings, where people already knew each other and had trust in each other. And it really spread like wildfire. Within about 6 months, we moved from 17 to more than 800 liaisons within communities, and over time, I'm sure it would go even further, but we hadn't tracked it beyond that. Tom Valenti, a friend of mine, came up with this notion of social network thresholds. Personal network thresholds are the number of members within a personal network that must have adopted a behavior before one will adopt. It has a lot to do with the strength and influence of individuals within a social network. And by knowing this threshold, you can make good decisions about how robust your intervention needs to be, how many people you need to involve, and how you can track change and predict change over time. You account for some variation in overall adoption time, and opinion leaders have lower thresholds and influence individuals with higher thresholds. So once again, you identify those key people who believe in what you're doing, who are credible and influential, and have them carry your message. It's kind of like the two-step flow notion of that, you can't do it yourself, but you engage others to intervene for you.
So methodologically, what is the way in which we collect data for the social network theory? Is it
Network analysis.
network analysis?
Yeah, network analysis, basically it's survey data. You
Okay.
collect survey data about who you communicate with, and what
Okay.
influence, and what you talk about.
Okay.
And then you run it through a program like NegaP. There's a bunch of them that do, and then it comes up with a diagram of who the people are, what the influence is, and then you can figure out who you need to contact. Now that's the formal way of doing it. The informal way of doing it, qualitatively, is to go out and do interviews and talk to people and find out who the maidens are, who are the key influencers within that group, and then work with them. I tend to do it the informal way because it's quicker. Some people like Valente and others end up doing a more formal analysis. There's a lot of people, Peter Manji and Nash Contractor, who do really very elegant modeling of social networks. Conclusion. Social theories and models see individual behavior embedded in social and cultural context. They tend to focus on norms, relationships. They look at issues like gender imbalances that create the meanings and determinants of behavior and behavioral change. These theories dictate that efforts to affect change at the community level will have the most significant long-term impact on individuals who are contemplating changes and on those who have made changes but need support to sustain those changes. So now you have the social system working with you. It's kind of like, a lot of times I think that interventions are like the Lone Ranger, They're on, I'm going to do it all by myself. And it's kind of like, I think, it's like folly to think that you can have this kind of influence by yourself. And maybe if you're in a position of authority, people will listen to you while you're there. But once you're gone, they go back to their old way of doing things. You need a lot of reinforcement. You need to get that social system working with you. I think in particular, getting family support for behavior change is really critical. Social theories have been increasingly used with populations who are especially vulnerable to effects of partners and peers. All right, now the next level, and this is the most complicated level, are the structural and environmental models. And I've been using these more and more because partly because I've bumped into hard walls many times where I thought things were going to work. I built all the things, and then the social system just kind of didn't let me do what I wanted to do, and were constraining changing behavior. So this approach looks at health behaviors within the social and environmental systems. social systems can either inhibit or promote healthy behaviors. To change healthy behaviors, social systems need to be modified to support the new behaviors. For example, the Socio-Ecological Model. Pattern behavior is the outcome of interest, and behavior is viewed as being determined by several structural factors. Institutional factors, social institutions with organizations that have characteristics that rules, regulations that either support or discourage behavior. Community factors, relationships among it, and this is like the social model, and it involves that. Physical and structural factors such as environmental design and community resources are all factors that will lead to change. And then policy factors, regulations and rules, both formal and informal, that encourage and regulate behavior. So here's a pretty picture. I like the colors. You can see it's a hierarchy, and in many ways it's kind of models the different types of theories as well, moving from the individual level to social, family, and community networks. And then you look at the structural and environmental, both living and then broader conditions and policies within nations and even internationally. Edutainment is another structural, environmental, systemic approach that combines entertainment and education and then the larger media environment to support change. That we're all immersed within a powerful sea of information provided by a range of different media, and that information environment is getting more rich and complex by the moment with all these different channels of information. And typically when we try to do an intervention, we're looking at one or two or three, the most, channels, and then we've got all these competing sources of information. If you can't get these other sources of information to reinforce what you're doing, they will overcome you. So here you want to try and figure out how can you get the most dramatic, memorable, interesting, relevant, exciting, fun channels of communication to work for you. Sounds good. The problem is getting the media producers to work with you, and it sometimes can be expensive unless you can convince them. So you want to make health education efforts entertaining, you want to make them engaging, you want to enhance the news value in health messages, you want to increase accessibility of health information from a wide variety of channels, you want to make health information persuasive. All these are factors. Health messages often fail to capture attention because they're boring and unimaginative, complex and technical, intimidating and frightening, insulting and disempowering, directive and prescriptive. So you want to try to avoid that by making them engaging and fun and interesting and dramatic. So you want to have a story. You want to tell people about people that they can identify with. You want them to kind of drop their everyday behavior and vicariously experience a whole new set of ideas in a very vivid and dramatic way. You want people to laugh. You want them to cry. These are not the typical issues you see in health campaigns that are often very shallow. So here you want to really enrich them, providing vivid models of health, adapting messages to audiences, using multiple complementary messages, illustrating concepts both visually and especially narratively. I think the story is really the critical piece in edutainment. Providing subconscious encouragement for behavior over time and tailoring messages to individuals. Another model that I use a lot is Weich's model of organizing. It describes the use of communication to manage uncertainty within social networks. Basically, it says that we try to maintain an optimal level of understanding so that we can handle situations. We want a little uncertainty in our lives because it makes life interesting and exciting. If we knew everything, we knew what to do, life would be boring, So we want a little drama, but we don't want so much drama that we're totally, confused and baffled. I'm always trying to manage that level of, planning out what I'm going to do, but not really over planning it and kind of like letting things emerge a little bit, living a little bit of edge, but not being totally out of control. So you got to be somewhere in between there. Promote informed action. I talked about the notion of requisite variety, that you act appropriately to the situation. The complexity of the situation determines the best courses of action. One of the big problems in health behavior and health promotion is that people engage in overly simplistic behaviors that don't match the problem. For example, they don't really take seriously health risks. They engage in behaviors that are detrimental to their well-being because they don't really understand that to achieve their goals they need to engage in more complex behaviors. Sometimes people think they can do very simple things to solve all their problems. That one of the reasons that there's a problem with substance abuse is that people think that if they get stoned or drunk, that whatever problems they have will go away, and they do temporarily because they are distracted by being stoned or drunk. But typically they come back in spades later on because not only were they not dealing with the problem while they were stoned or drunk, they usually engage in behaviors that actually make those problems worse. And that happens in a lot of different ways. It's kind of like the Band-Aid approach to dealing with problems. If you have a serious infection, and part of that is that you're bleeding, and your way of dealing with that is by putting a Band-Aid on it. It's not really dealing the underlying cause, and while you're stopping the flow of blood for the moment, whatever the underlying cause is getting worse. So you need to really deal with the level of complexity of the problem. Encouraging cooperation, non-summativity, so you need to have people within communities working together. The notion that no one person will solve a problem by themselves is here, and their communication is the critical piece of sharing information. Enable optimal coordinated performance, synergy. You notice that there's a lot of systems concepts here. This is a model that's based on systems theory, and I love systems theory. Facilitate interpretation of complex systems. Enactment. This is a communication thing based on perception. Helping people do a better job of understanding the constraints and demands of their health situation. This goes back to the Elaboration Likelihood model, because here you want people to have a better understanding of what's going on, rather than just superficially dealing with all this dengue. What does that mean? How does that work? What are the risk factors? What can I do? Really understanding it as fully as possible and evaluating the complexity of that problem. So that's called enactment processes. Guiding coordinated responses, which means that you communicate with people to come up with strategies for responding. Once you've figured out how complex and deep and what the issues are, then you need to figure out what you can do about it. And a lot of this is based on past behavior, what's been done in the past, what's worked, what doesn't work. If it's totally novel, you need to come up with different strategies. You need to identify people in social networks who have specialized expertise who can help you. And so as an interventionist, what you want to do is you want to connect people who don't have a lot of information and are at risk with people who can help them to provide information and support and provide channels of communication. I think one of the big problems in negative health behavior is people really don't know good alternatives. They don't know what to do about it. Sometimes they don't recognize the problems, they don't understand it. When we were doing interviews with people with chronic diseases about why they weren't taking their medication, it was amazing to me how many people didn't really know what their diagnosis was. They didn't really think they had that problem. They didn't really understand what the medications were for. Didn't realize how important it was for them to continue taking the medication. So they really hadn't done a good job of enactment. And because of that, they didn't really select the appropriate strategies to engage in. They needed more information about that to help them. And then based on selection and what works and seeing what works and doesn't, you retain that information as guidelines for the future. This is called organizational intelligence. So basically, as an interventionist, what you're trying to do is to increase the quality of communication so that people can do a better job of ascertaining what the problem is. Elaboration. You're helping them select good strategies and engage in them, and then learn from that so that the next time this problem happens, they already know what's going on so they can maintain appropriate behavior over time. So here are the critical components: interacting within complex information environments, recognize the equivocality or the uncertainty that's involved, and how you can engage in conjoint relationships with people to reduce or cope with complexity, how the system functions, how different this happens not only at the individual level, but one of the beauties of Weich's model as a systems model is it looks at it on multiple levels. Within the individual, within the family, within the organization, within society, across nations. There's subsystems and systems that all fit together. All these pieces are interdependent and work together. You need to promote non-summativity so that we're cooperating with each other and we get larger outcomes, which is synergy. Equifinality means that there's no one way of doing things, but you can be creative and come up with different solutions over time. And then you want to try and reduce the drag on change or the threats, neg entropy. Entropy is like all the things that lead us to become disorganized. It's all the things that drag us down, like health risks are forces of entropy. What you want to do is promote negative entropy, ways of avoiding those threats, coping with those threats, overcoming them. And so the system becomes smart enough to promote healthy living over time. Ideally, at least. And so you're building an adaptive social system that adapts based on complexity and utilizes communication as a mechanism for enacting social change. You want to help them develop interdependent communication rules and cycles. We talk about rules and cycles. Cycles are basically interdependent interactions we have with one another to try to make sense of equivocality and identify new ideas. Every time you engage in a interaction, White calls it the double interact, act, response, and adjustment. Every time we do that, we reduce a little bit of equivocality. We make things more understandable. So you want to provide people with lots of opportunities to engage in these double interacts, hopefully with key people, experts, like from the social network theory, who have insights and information, as well as through the internet, through books, through hotlines. There's a lot of different ways of getting information, and so that people can engage in these cycles to reduce equivocality, and based on what they learn, develop rules. Say, yeah, this is how we deal with this problem. So we have a smart adaptive system. The next time you have this problem, for example, you get the flu and you feel terrible and you don't know what to do about it, and you go out and you talk to people, you go to the doctor says, do this, that, the other thing, get sleep, drink liquids, take this medication, and in a couple of days you feel better. The next time you get the flu, you don't have to go back and say, what am I going to do? You've got rules to guide you before, because you've learned about it. The big issue is retaining that intelligence and systematizing it so that people can use it over again. And then you engage in the process of enactment, understanding the system, selecting approaches, and retaining it to try to achieve your goals. So it's based on organizing all activities designed to reduce equivocality, enactment, processes of acting out or making organizational members construct meaning and make sense of their environment. Members construct meaning through interaction, so you want to promote positive interactions to help people work together. So this is a model that encourages, building systems of feedback, building systems of social support. Yesterday when we were talking to Mohan about his thing, I know if you noticed I was pushing him to try to build feedback systems in there. So it's not just like, they have like this one-time communication, is that going to be enough? If people are unclear about that, can they ask questions? Try to get them to build in social support systems where the women can talk to each other and help each other and encourage and provide information and insights that only they would have. They have that expertise. So here, it's based on working with the environment, changing the information environment. How do you make sense of the environment? How do you deal with equivocality or uncertainty? How do you retain information over time? And then how do you retain that information so that you can use it in the future? So here's a picture, a bad picture. You're starting out with ecological change. I'm sorry for all the jargon. I try to demystify it. Ecological change is a threat, a health threat. So let's say dengue fever is the ecological change. There's dengue fever in the environment. So what do we do about that? First of all, you need to help people understand what the heck is this dengue fever, why does it happen, how does it happen, am I at risk, so they can understand it, and they need to engage in appropriate cycles. You can judge to yourself how effective the government has been in educating people about dengue fever. I've seen stuff on news, I've seen in the newspaper, on television, I've seen posters, but I don't know how well people understand. Do you think they understand what the risk is and how the risk occurs? If they do, then they're doing a good job of enactment. If they don't, then they need to resolve equivocality further. So you've got to evaluate where they are with that. I suspect that people need more sources of information. They may need more close sources of information. A lot of the information is pretty distant from officials that are, they can't identify with, and there's not a lot of opportunities for feedback. For example, in the bus situation, if it raises your questions, who do you ask? Do you ask the screen on the back of the seat? That's not going to tell you anything. It's only got a limited amount of information. And I think that one of the problems in health interventions is they don't provide enough opportunity for interaction. There's not enough information processing going on. One of the things that we learned in the work I was doing with medication adherence is that the big problem was the doctor was telling patients what medication to take, but they weren't really explaining to them why they needed to take it, or how it was going to work, or what alternatives they had, or what kinds of issues they might have, or side effects. Didn't really explain to them, that they needed to continue to take it. There wasn't often a good explanation of the nature of the health problem. A lot of people would thought that long-term chronic diseases were, short-term things that they could solve right away. That people would say things just like, I used to have diabetes, but I took medication for a couple of weeks and I'm all better. Not realize that the medication doesn't solve the problem, it just helps to manage it, something needs to manage. And you hear the same thing with cardiac disease and mental health issues. I used to be schizophrenic, I took medication, I feel better, stopped taking it, now I'm great, I'm seeing all kinds of colors, it's wonderful. So it's a real big issue of trying to help people really understand. Once they understand, then you can move to the next stage of saying, what do I do about it? So if you can really help people understand what the risks for dengue fever are, and what are the different parameters, then they can say, well, okay, if I know it's mosquitoes, there's areas where I might encounter mosquitoes, and I'm going to be in those areas, there may be things that I can do. There are things I can do to reduce the likelihood of having contact. I can put things on that will repel mosquitoes. I can avoid those areas. I can maybe encourage changes in the environment, kind of a environmental approach to remove mosquitoes from that environment. And then if those things tend to work, then I need to remember that and talk about that and retain it as organizational intelligence. So next time something like dengue fever comes along, we don't have to go through this whole process. We already know what to do. Conclusion. Community level theories, models, and factors see human behavior as a function not only of the individual or immediate social relations, but is dependent on the community, organization, political, and economic environment. And I should also say in physical environment. These models are multidimensional with an emphasis on linking the individual to surrounding larger environmental systems. Interventions using this approach target organizations, communities, and the policy environment. And I think the best interventions will look at these bigger social structures. Now the problem is, this is more complicated to do. It's much easier to focus attention on the individual. You have a more simpler message system, you have fewer people you have to involve, you don't have to deal with social norms, you don't have to deal with political structures, you don't have to deal with a large political and organizational bureaucracy. But the downside is if you don't do that, you're not going to really be as effective of influencing change short-term or long-term. And so I think it's really inherent upon us as sophisticated interventionists to think about ways that we can look at this in a broader, more encompassing way, and to build in structures of support within social systems through key influencers, through officials, through legislation, through environmental changes. I mentioned to you a couple days ago about this project I did with the National Recreation and Park Association, where we changed health behaviors within a very poor inner city community in DC by building a new park system and cleaning up the area and pushing out the drug dealers. I mean, a lot of people said to me, what does this have to do with communication? Is this a communication intervention? I said, yes, it is. Because the way our environment looks communicates a lot to us, cues us as to what kinds of behaviors to engage in. And it sets the stage for behaving. And those environmental changes were enacted through a community participative process that changed public attitudes and logics about what's appropriate and got people to talk to each other about what it is they wanted from their community, what it is they wanted for their children, how they wanted to live their lives, how they wanted to eat, how they wanted to exercise, and got them to start thinking about it and then develop new logics, basically organizational intelligence, for how we want our community to look, and then how we want to behave and how we want to promote health. So it had powerful implications. I think sometimes the physical and structural factors are things that we don't really deal with as communication scholars, because we're focused more on the the overt, mediated or interpersonal messages, and not on the larger nonverbal messages of the environment. But we're so powerfully impacted by the worlds that we live in, and I think we need to start thinking more in more sophisticated ways about what communication is. That this building design is a powerful factor in encouraging interaction or discouraging interaction, of encouraging cooperation and discouraging cooperation. They know, like environmental designers, how important design is for either discouraging or encouraging criminal activity. Lighting, space, design, interaction are powerful factors. I think the same thing we need to start thinking about in terms of health promotion. Lessons learned. These are my lessons I've learned. I don't know if they're good lessons or not. What I've learned is that I need to really segment target audiences by key behavioral factors. That was the health belief model. Taught me that. I need to design interventions to meet unique audiences' needs and beliefs. I need to design culturally appropriate materials and messages that really match the social norm system and structure that exists within communities. I need to capture audience attention with vivid and engaging messages. I need to involve consumers directly and actively in campaign design and implementation so they feel a sense of ownership, and I get the reality base that they know about that culture. They're the experts, I'm not. I need to involve family members in social networks, and family members are really critical. And it's really sad, but most interventions don't involve family members. And we really need to do more. My colleague, Carla Fisher, who does a lot of work with, you may know, she's out of Penn State. She worked with John Nussbaum. She takes a lifespan approach to healthcare, and she works with mothers and daughters communicating about breast cancer. And she's found that by influencing that social structure and encouraging dialogue, it's made major changes in behavior and outcomes. Build social and structural support for behavior change. Provide appropriate training and support, particularly if I want people to use new media technologies or applications or technologies. I think we're all really, I am particularly, I don't know all, but I'm really giddy about all the new technological tools. I love all the toys. I like tailored information system. I'm crazy about the use of virtual human agents. I'm trying to do all kinds of really cool things. And then I need to have kind of a dose of reality. Do people have access to this information? Do they know how to use this technology? Is there funds available to do this? Is there ways of maintaining it? Particularly when a lot of the interventions for marginalized populations are with elderly people who are really affected by the digital divide, poor people who don't have access to those resources. And as we were talking to Mohan yesterday about the women that they're targeting, they have very, very limited resources. They don't even have smartphones. They don't, they're not going to utilize any of these technologies, and they don't know how to use it. And they're speaking 6 or 7 different languages and dialects, and so I need to maybe rethink how I'm going to use technology, and if I'm going to introduce something new, I better train people and support them for using it. I did some research when I was at the National Cancer Institute called the Digital Divide Studies, where we tried computer-based interventions with at-risk, poor, low education, elderly, range of different populations, and found out that they could be used effectively if we provided sufficient training and support. But that was a critical factor in getting them to use these technologies. Help reduce uncertainty through interaction and build in feedback loops and interaction loops and discussion and access to information for consumers and connections between consumers and providers into interventions. And that's a lot of the work I do is building new tools for queuing people and sharing information. One of the real benefits of the advent of electronic medical records is as a way of sharing information among people. I do a lot of work with the Veterans Administration in the U.S., and they have a particularly robust My Health eVet program, which is a medical record system that is open access to all healthcare providers in that system and all veterans. Every time a veteran goes to be seen, their record is up on the screen. All of their providers get that information. There are flags for what they need, what they don't need. They own that information. They have access to it. They can get printouts. It's it's a very good system for getting collaborative and cooperative and continuity of care over time. And so it's a really good way for me to share information. I think I may have mentioned that one of the projects I'm working on now is end-of-life counseling for veterans who are advanced care cardiac patients who are likely to be dying within the next several months. The cardiologists were not identifying those patients at risk mainly because they didn't want to deal with them, didn't want to communicate with them, but also because they didn't want to admit that there was nothing else that they could do. And so we developed an online information tool that was built into the electronic medical record that calibrated different physiological factors that ranked people in terms of their risk of dying and flagged them for the colleges and mandated that they talk to them about it so they couldn't avoid it anymore. It was an information system that was built in that promoted interaction. And I think there's lots of ways of doing that. I think that the new technologies are going to provide more opportunities for feedback and information sharing if we think about it that way. Unfortunately, a lot of health information systems and other information systems are designed in proprietary ways that only privilege administrators and legislators and decision makers and not the populace. And that's why I'm such a big proponent of open source, of making things open and transparent and accessible. And I think that if it's going to happen, we're going to have to push it as interventions. When we design these things, we have to demand that information is available. One of the big fights that I've had, and I'm probably going to continue to have with my colleagues at the Ministry of Health in China, is to make the data that we collect about health information access widely available to healthcare providers, to consumers, to advocates, to the public health departments, so they all use that information. That's not been the tradition in China. The Chinese government holds information very tightly, and they wanted to keep that information. First of all, they didn't want people to know that there were problems. They were really worried about bad press, and so I still am having problems that reporting data. So they need to make sure that the data is not embarrassing to the government before we can report it. So what we were focusing on is ways that they're using that information to improve outcomes, so we can have kind of a positive light on it, but still making that data available. Because if they don't make the data available, people can't use it. It's not going to do any good.
Excuse me. It's also a privacy problem, right? It's like sometimes they worry about the privacy, like the patients don't want to share some kind of medical conditions.
That's a big problem in the U.S. with the HIPAA regulations. There are regulations about sharing information. So one of the things we need to do is to build ways of protecting the information, making it passcode, available when we report information broadly, is stripping all identifiable factors to individuals so people can maintain anonymity or at least confidentiality. And so I think that's one of the big issues in providing health information. There's especially concerns about it because in the U.S. in the past, hopefully this is going to change now with the Affordable Care Act, but in the past, then insurance companies could, preclude people from having insurance if they found out they had a serious health problem. So if you found out people had HIV or cancer or something else, they can say, well, we're dropping you from our policy because you're going to be too expensive for us. Now they'd be able to do that, so it's not going to be as big an issue. But then there's also stigma issues of people not wanting to know that they have HIV or have cancer or have epilepsy or have mental health issues. So I think those are big issues. I think to a certain extent, we may have to give up some of our privacy for access to information. I think there's got to be a dialogue and a judgment about what are the risks and the advantages. And I think maybe that consumers need to be in control of that. There's an organization that I'm pretty actively involved in called the Society for Participative Medicine, and their primary goal is to provide access to relevant health information to all consumers, so they can be informed and they can call their own shots in terms of healthcare. In fact, the mantra, the driving mantra behind that organization is "Give me my damn data." I'm not kidding. That's what they say. Everyone says, "Give me my damn data." They're fighting with the healthcare system to get access to their health information, and it's amazing how resistant hospitals, clinics, insurance agencies are at giving people their information. They put all kinds of roadblocks in the way. And not only giving it to them, but giving it to them in a way that they can understand and use and educating them so they can cooperate and collaborate on healthcare. And I think that we can develop information systems that will promote sharing of information. It really fits into issues, models like the Elaboration Likelihood model, because they have more information available to understand. It really works with Weich's model of organizing, because it promotes interaction and sharing and solving and adapting information. It becomes a more powerful way of promoting change. It focuses in on diffusion of innovations, because it allows you to identify key opinion makers and get them involved in sharing information. So I think that there's real value to providing more access to information. Provide multiple reinforcing messages. I think I mentioned this earlier, is that I think one of the big problems with health promotion campaigns is limited exposure. And so I really want to provide a variety of ways to get information out that encourage and reinforce and build on messages over time. Use multiple close and familiar channels. Refine strategies based on evaluation data. And tomorrow we're going to talk a lot about evaluation data. And then institutionalize and sustain the best programs so they operate over time. So they're not one-time, one-trick ponies. They're things that really make a difference. Here are some of the references for some of the theories. I'm going to make all of my slides available. You are free to use them, steal them, publish them, do whatever you want with them. Please don't publicly humiliate me with them. Other than that, but if I'm talking about open source, I really want you to have access to all of my information too. Everything that we talked about, I think there are six now, because 6 PowerPoint programs that are some of them pretty detailed. Hopefully they'll be useful for you. All right. Let me stop with the theories. Sorry for how much I gave you. And I didn't hit all of them. I left out a lot of good ones. But I just didn't want to kill you. Which are the theories that you find most appealing that you might utilize or are currently using in the work that you do? Which theories do you like?
Sorry?
Which theories do you like of the ones I talked about? Which ones appeal to you as models of theories that you could use? Any of them? Thank you off the hot seat. Somebody else.
I think currently I kind of like using the combination of usually like theory of planned behavior and social cognitive theory. And the interesting part is that more or less eventually the factor self-efficacy would emerge, and then you just need to include that variables in the research. But actually that links to a question that I have to you, is that based on your experience in the field, do you think that we already exhaust all the factors that we can identify in the field of health communication, especially at the individual level, right? Because over the years we can see that most of the the behavior change theories like health belief model. We've been using that for more than 30 years, and it still stands strong, right? It is still very applicable. So I'm just curious that you think that do you see a need for us to find out more factors at the individual level, especially, or you think that we should, pay more attention to develop new theoretical models at the social or the structure?
I think they probably need for better models at all three levels.
I don't agree.
I think that there are probably individual factors that we're not focusing well enough on. There are some really interesting evolving models of social support that identify key individual factors that make people more or less predisposed to providing and receiving support that I think are really interesting. I think that we have different normative and cultural factors that we may need to take into account. I think that, for example, one of the big issues in developing tailored health information systems is finding the right individual factors to tailor messages on. We've been using, basic demographic ones in the past, male, female, age, education level, geographic background, ethnic, language. But I think there may be some more sophisticated ones. For example, my friend Matt Kruder has been doing some really interesting applications based on levels of religiosity.
I was about to say religion makes a huge role.
He found that how involved people are in their religion becomes a major factor, and then if they can embed messages that are reinforced by the religious beliefs, they're much more powerful. It also identifies key sources of information from within religious systems. And I think there are other factors as well.
Yeah, like information seeking nowadays, that's like an area that people are keen to develop new models or theoretical framework.
So I really think at all three levels that there are opportunities for refining and expanding these models. The model that I didn't put in was the relational health communication competence model that I've developed. I'll send you some information about that. It's also a social systems model that's based on trying to build in information and support in relationships. The notion is that the more effective relationships are between key people within the healthcare system, including among family members and with providers and with other people who have similar health problems, the better the outcomes are, because you get access to the information and support you need to achieve your goals. And I think that's really a really nice approach. I use that quite a bit in the work I do to try to help people develop meaningful relationships. And it could just be like the doctor-patient relationship, but it could also be, within the family, like the work that my friend Carla Fisher does. It could also be social support systems, like online support systems.
Recently, because I and Isha, we are working on the project that involves that exploring how women they receive social support, and then what's the impact on health behavior. And then we realized that actually the concept social support has been pretty intensively explored in the field of sociology. They already have all the very well established scale, social support, you have these 3 dimensions: information support, emotional support, physical support. And we were pretty surprised that actually that kind of literature hasn't been broadly discussed in the field of communication. So actually today's lecture is very useful, because I can see the way to combine that part of the literature with social network theory, and then to provide new information into that area of research. So I'm really excited.
No, I agree. I think that's a really critical social network, is what are your support networks?
Right.
And what are the strengths of those support networks?
And then thanks to the advance in methodology, right? Because social network analysis emerged in these 10 years that really help us to got a new tool to analyze how people communicate with each other and interact with each other. So I think that's a very fascinating field.
I use a lot of the individual level theories that you spoke of, socio-cognitive theory and ELM in my own research in a different context, and I am very familiar with all of the individual levels, but I'm not at the community level. I mean, I know the diffusion of innovation, and I would probably put the entertainment education along with that level. But I'm just not at all familiar with the Weick's model, which I thought was very different, and then it brought in some.
I have an article I wrote a couple of years ago in Patient Education and Counseling that described how Weick's model can be applied in healthcare. It's actually taken off quite a bit. A lot of people are using that now. It was a kind of a new idea. The model was actually developed for organizational behavior. He's an organizational psychologist, and hadn't really been applied in health very well. And so I'll be glad to share that with you.
It has a lot of terms and concepts like social cognitive theory. I think it tries to encompass a lot, but I think there's a lot there in terms of like how do you change the rules, the organizational intelligence, how do you preserve it. So when you look at it from a systems approach in terms of policy changes and regulations and maybe even incentives, then the idea of incentives.
The thing I like about the model is that it privileges communication.
Yeah.
It's a model that basically says everything is based on the effectiveness of communication. That if we're going to try to make changes and achieve goals, we need to really promote sharing of information and collaboration between people. You know, it appeals to me as a communication scholar. It also appeals to me as kind of a communitarian. And I like the notion of building community and connecting people and working together. You know, I think this whole notion of everybody do it all by yourself is not a very helpful one. I think we need to find ways of getting people to collaborate more. And so this is a model that really privileges that collaboration. All right, I'm going to shift gears to message design, which was really the theme that we're supposed to be talking about today. but I think the theory is very, very interesting. And I think that good theories are like, really good tools that help us achieve things, that give us direction. And so I think having a very strong and broad grounding in a range of theories gives us the ability to understand intricacies of social phenomena in very intricate ways that normally we would not be able to do. It really enlarges our scope and understanding of the world. And it also gives us a direction so that we have a strategy that we can use. The big problem is that I see that people are very overly loyal to their pet theory. That the people who are trained by Marty, they better not use another theory,
More.
Right, exactly. Is that I think that we need to kind of think about having multiple theoretical perspectives and having broad use of different theories. I don't really want to get into the kind of like gunslinger thing of my theory is better than your theory, and there's been a lot of that. People get very, this is the whole thing about scientific revolutions. People get very, caught up. And not only the theories, but often there's a methodology that goes along with the theory. And so, I only do this methodology. In our graduate program, we really take great pains to train people in a wide range of different theories, different models, different methods. When they come out of that program, they've got to be good at doing everything. It's not easy for our students. Ask JT, when he comes back, we really made him suffer.
Crazy for your program.
Yeah, JT got his PhD with us. And by the time he came out, he didn't really want to be a qualitative researcher. That was not his thing. But, we wanted people to be able to use a variety of different tools and be able to do a lot of different things. So I think it's very healthy. in many ways, our discipline is better than others. In some disciplines, there's like Cold War. Anthropology between the quantitative and the qualitative anthropologists, sociology, even psychology. They don't talk to each other. Sometimes they've broken into different departments. Based on methods, and I don't think that's healthy. So, and I think one of our strengths as discipline is that we are multi-methodological and multi-theoretical, and we're not afraid of adapting and adopting theories from different fields and extending them and using them. I think it's one of our great strengths as a discipline. Maybe it's probably because of our youth as a discipline that we may be a little less regimented and more exploratory.
And also the pragmatic value of the research. That's one of the major difference between Housecom and other subfields of research.
Let me ring up a different PowerPoint. This one is much more pragmatic. This is more like a how-to.
I use a lot of framing, priming, agenda setting, cultivation because of the media influence as well.
Yeah. Media doing
And the attribution, causal attribution, because that might be interesting, causal attribution, whether you place the responsibility of health at the individual or societal level.
Health promotion professionals at the CDC, and I just kind of adapted it a little bit for us. It was I was doing a training program for a group of about 20 health promotion professionals who their job was to develop websites and brochures and programs in a range of different areas, from infectious disease to HIV to cancer to injury control to environmental risks, and there's a broad range of different people. And so I wanted them to learn what to do to design better materials. So it's about strategic design of health communication interventions. Started off by talking about evaluation data. One of the big problems at the CDC and probably other government agencies is that they're really pressed for time to, this is a program I did at a workshop for CDC. Oh, I'm so glad you brought that up. You share with me. I'm getting hypoglycemic right now. Thank you. Is I want them to encourage them to do more formative evaluation before they develop campaigns. So I wanted them to think about how effective were the different products that they developed for use with diverse and at-risk audiences who often possess low levels of health literacy. Because those are the audiences that primarily they're dealing with. The mainstream audiences, people with well-educated and have high literacy, typically don't have as big problems. Now, how do you develop health communication products to make sense to these at-risk, low education, low income, low literacy groups? I wanted to help them figure out how to conduct audience analysis and determine optimal message strategies, and also wanted them to engage in usability testing. Do you know what the difference between audience analysis and usability testing is? Audience analysis is typically ahead of time, when you're trying to figure out who the audience is and what their comments are. And usability testing is after the fact, once you've developed at least the draft tools to see how well they can use them. It's basically checking to see whether or not your audience analysis was good enough to design targeted materials that really made sense. And even with the best audience analysis and best intention, we find that a lot of times these systems and products and programs that we design are clunky, and they don't work really well, they don't make sense to the individual. And so it's really important to not just throw them out into the community, even with good evaluation data, but to make sure that they're formatively evaluated and refined.
Is it also called message testing, or is that That's the term that I
Yes.
use. It's a synonym.
You message testing, but it's even more. It's actually used in the programs. For example, we design a online website. We'll take them to the website, not only ask them to look at the programs, but see if they can navigate.
Okay.
Can you get the information you need?
Yeah.
Do these systems work?
How user friendly is it?
Right. How navigable, how usable is it? I take a persuasion perspective. McGuire. An oldie but a goodie. And we've all probably read his work in graduate school.
Yeah.
Bill McGuire. He was a very smart guy. He talked about a number of key factors that we need to think about. Exposure to message, which is a big problem. Attention to message. Do people like, are they interested in the message? Do they understand the message? Is it appropriate to their individual life? Is it personalized for them? Are they willing to accept the recommendations, right? Can they remember what you told them? These are a lot of the things you use in message testing to find out. Can they retrieve the information when they need it? Do they have the information to make good decisions? Can they actually act upon what you're doing? Without adequate comprehension and all these factors, successful persuasion is not likely. So these are the things that we're trying to figure out in message testing to try to identify whether or not we're doing the right things for specific audiences. So we're getting key data from audience analysis to see whether or not we're going to achieve our goals. We want to know who the target audience is, and so we need to think about up front, who is it that we're trying to reach, and sometimes it's multiple audiences. I often find when I'm working with health promotion deals, they're lumping together from very different audiences, which causes them tremendous problem because they have different message needs and capacities, and it's not likely they're going to come up with one set of messages that's going to work well. Thank you, Paul. You get extra points.
I steal it from you.
You did that more than
So you need to figure out who it is that you're dealing with and then design messages for those audiences. Audience analysis is actually a really good way of helping you to figure out who the different subpopulations are so that you can do good segmentation. Because the audience analysis will tell you which groups tend to kind of hang together based on key audience characteristics, key message factors, key communication capacities, and orientations. I say that audience analysis is a prerequisite to creating communication products. The reason I did that is because I was really appalled to learn how little audience analysis was going on. In many cases, the most audience analysis that went on was identifying which groups they wanted to reach without really doing any kind of background information about them. And a lot of it was based on tremendous stereotypes. And also, lumping a lot of people together. Even with them, for example, they said they wanted to reach African Americans. Well, there's a lot of different groups of Africans. There's well-educated, there are poor, there are professional. There's people who are African American from Africa. There are people who've been here for multiple generations. It's crazy to lump all these people together because they have different issues, different needs, and you're going to have to try and figure out who they are and how to communicate with them. Products based on rigorous audience analysis are likely to achieve key goals as being personally relevant, promote attention, comprehension, consideration, and then accepting the things. Basically, this is saying that we can achieve McGuire's goals if we do good audience analysis. A key issue is that one size does not fit all, which is not a happy thing that people want to hear. Because they want to do one simple, pervasive, inexpensive, widely used intervention for everybody. Everybody wants to do this, but and I'm basically bursting their bubble whenever I go and say no, that's not going to work. It's not going to do it. Low literacy materials in particular have to be developed specifically for the unique population based on their unique literacy skills. A lot of times people say, well, I really don't want to dumb down these materials. I want to maintain the quality of information. I said, well, you can do that, but you need to provide it in a way that people are going to understand. And you need to match the information to literacy levels of intended audiences. And from what I'm hearing about Singapore, I think the literacy issue is a really big one. There are basically three related factors: a health literacy level, cultural competency, and the specific language that people use. I think those are the factors that are really the three critical ones in trying to design messages. There's a program, an online program that's open access that I helped design for the Health Resources Services Administration, HRSA, which is a very large government agency in the U.S. that is the primary healthcare provider for indigent populations in the U.S. They do it through the Bureau of Primary Care. That's like they have about 1,500 clinics all around the U.S. in the poorest areas, rural and urban areas, where they provide free care, basically Medicare, Medicaid care to immigrants, to migrant workers, to homeless people, people with all kinds of health problems. And because these people have very low literacy, the providers have a very difficult time communicating with them and delivering care. So HRSA decided they were going to develop a training program for all of the providers that they have. And there's tens of thousands of providers that work with HRSA. So we developed an online program on health communication competency. It was called the Integrated Health Communication Training Program. And we made it available online. And it's an interactive online system that's now been used with about 30,000 healthcare providers and gets very good response. And I'll send you the link so you can get into it if you want to check it out. And it deals with those three issues of cultural competency, health literacy, and language use.
What are those clinics called? Are there any specific names or?
For what?
For the 1,500 clinics.
Yeah, the Bureau of Primary Care. There's the National Cancer Institute has been a real leader in the development of culturally sensitive health communication materials. I had a little bit to do with that, but it was actually even before me. They have a tool called the Pink Book.
Yes.
And this is the link to the Pink Book online.
It's a very good tool even for teaching health communication.
Right.
It's a course.
So this is going to be very familiar because it's not really complicated. It was very basic. One of the things I want to do is to make information more interactive so that people can ask questions if they don't understand. Present how-to information so people know exactly what it is you want to do, not to assume they know what it means to take a medication or to dress a wound. That you give them very specific information. Provide very familiar words, and when you provide new words, you define them. Use simple sentences, direct and active voice. Use concrete examples rather than abstract, and highlight and summarize important information both verbally and graphically. In terms of layout, both our online and print materials try to organize things so that people are directed to the key information, using organizers or headers to direct attention, make them very simple and close to text, provide a lot of white space so there's not really a thick text, particularly people who have reading problems. You can really intimidate them with a really dense, underline bold rather than caps to give emphasis. Use type style and size that are easy to read. Ensure things are simple and free of clutter. Only provide information that's most relevant to what you're trying to achieve. Make sure that the information you provide is provided in a way that's meaningful and appropriate to the audience. Depending on what your audience is, you're dealing with adults, and these people are mostly dealing with adults. Make sure the images are, are things that they can, identify with. And then use visuals that illustrate the specific message. I also suggest the use of cues such as arrows or underlines to point out key information. I think that the best idea is to use multiple media, but a lot of it has to do with available resources and how much money has been allocated to the campaign. So I think they need to make some decisions about what they want to use. Print media is used most often in health promotion, primarily because it's not very expensive. But it's a real big problem with print media, is that a lot of people don't read. Then they may not pay attention. It's not a particularly dynamic medium, and it gets old very quickly. So there's storehouses full of pamphlets that are totally out of date and don't work anymore, that we wasted our money on. They have some new on-demand, quick printing mechanisms, so they can do very short runs on materials and then update them and change them. It's making things better. But I really think that eventually we're going to be moving to more and more digital presentation of information. Unfortunately, the digital divide still exists, and so I think you need to continue to use print. As much as possible in my own work, I try not to use print. I try to use digital information. But I think audio, video, interactive information adds more drama, more emphasis. Often it's easy to change and update. Video, maybe not so much. There's no real definitive answer about which medium to use, but each medium has their own particular advantage and disadvantage. And you've got to figure out, based on what the situation is and who you're dealing with, which one is going to work the best. As I said, print is still dominant, but interactive, dramatic, and visually appealing media are typically more engaging and influential. Audience analysis should be an integral part of message development. Literacy skills represent an important audience characteristic. Simple and accurate tests exist for literacy assessment. The messages need to be crafted in ways that will facilitate understanding. Now, how do you figure that out? It's through usability testing. And usability testing is not done nearly as much as it should be, so I'm a very big advocate. So the basic purpose is to figure out whether or not audience members really understand the message and the delivery system. It finds out whether the messages are attractive to the audience or responsive to audience needs and are culturally sensitive. So there's two types. There's the message analysis type, and that's what you've been doing, streaming. It looks at the readability formulas, it looks at audience responses. And then there's audience pretest, where you pretest draft material, assess comprehension, attraction, acceptability. Actually, I think you'll probably be doing both of those. Ideally, for low literacy products, both types of testing should be conducted. Pretest with audience members is generally considered to be the best evaluation method. Sometimes they don't have much money or time. So at the very least, they can just do an analysis of text to see what the readability level is and the comprehensive. And they can also look at the design factors. But I really like doing the actual testing with the audience. For print messages, it's often a good idea to first determine readability level. And there's several formulas. SMOG formulas is a very common one. It's actually kind of interesting when you can actually do it yourself. Well, I often will do this with classes where we take out text and we can evaluate it. Other message analysis is the SAM procedure, where you rate material as either superior, adequate, or not suitable on 6 major dimensions. And the total score will tell you whether material is suitable for your target audience. Item scores inform you of specific deficiencies in material so you can refine them. And then the audience pretest, which I think is really the best way when you're actually dealing with real people. What you need to do is find a representative sample. It doesn't necessarily have to be a large sample, although a large, if you want to publish the work and you want to develop materials, it's nice to have a representative sample. You start even before material is fully drafted, so you can test it at all stages. When you're just at concept stage or when you have fully developed, and it's probably a good idea to do it at multiple points of time. So the different ways of doing it, typically interviews and questionnaires are the key ways. Nowadays, a lot of message testing is done online, and so you have it built. Basically, it's you do like a what is the survey? Yes, Survey Monkey. There's a bunch of them. You can set them up, and so that you present material, and you have a bunch of different questions that they'll answer. I like interviews better myself, because interviews you can get more information and reaction, and you can observe nonverbals. People are not sure. They seem to be repulsed by the message. They think it's funny. You may not get that from the questionnaire, but you'll get that through the interview. And you can either do it structured or semi-structured or open-ended.
Focus groups work well for some of this message testing focus.
It does. The only thing I worry about sometimes is the interaction effect among the members. Sometimes I want that interaction effect, particularly when I want them to do brainstorming, particularly about refinements. But I don't want them to mute different voices. A lot of times in focus groups there's like one or two loud people, I'm usually one of those loud people. They like to talk, they want to hear the sound of their voice. And then there are the quiet people who may not agree, but kind of go along because they're afraid to rock the boat. And so I want to hear those quiet people too, because sometimes they're the ones that may not be getting it. And sometimes the really loud ones understand and others don't. But I like one of the really cool things about focus groups is that about groupthink, the fantasy chaining. There's Ernest Borman was a really well-known rhetorician and group communication theorist out of Minnesota, and he came up with this theory of fantasy chaining. It's a really cool theory. It basically talks about how people in groups can bring up an idea, and somebody says, "Wow, I like that," and it kind of makes them think about something, and they bring up something, and it gets other people. The next thing you know, they're all kind of thinking, coming up with new ideas, and focus groups, really do a lot of fantasy chaining where you get people moving in new directions, so you come up with new ideas. I often will use focus groups as ways to try and interpret evaluation data and apply it to coming up with new solutions. Okay, so if these are the problems and these are the issues, what can we do about it, and how will that work? And what could you do, and how would this work within your part of the organization, and who could do this, and how can you do it, and what are the constraints, and how would you overcome them, and what resources are available? And you come up with lots of great ideas and things that, as an outsider to the culture or organization, I would never know. And they know, and they'll come up with. Next thing you know, they're designing the whole intervention. It's great, and then they own it. And the people who are most excited, I invite them to work on it and get involved. And so, focus groups, I think, are really, really cool for generating excitement and new ideas. So, setting up the test, you recruit people. You make sure that their people are representative of the sample. You need to make sure. People have requisite literary skills to make sure they're representative. I usually do at least 20 or 25 to obtain relatively reliable results. However, testing only 5 or 10 is better than not testing at all. In some situations where I was doing the message testing for the medication adherence, I had a lot of resources, and I was able to do message testing with thousands of people all over the country, so I could get really good representation. Make sure you train interviews so they know what they're doing. Test materials in the same type of environment in which the audience will typically use the material, so that there's not a environmental effect on the outcome. Important questions to ask, and these go back once again to what we started with McGuire, comprehension, do they understand? Is anything unclear? What are interpretations of keywords or visuals? Is the information likable, attractive, interesting? Is the information acceptable, or is it, is it in some way unacceptable from does it break norms? Is it said in a way that's appropriate? Is it offensive? A lot of times, if you don't do this, you end up coming up with materials that people are really put off by, and it undermines your entire effect, because instead of hearing your message, they're thinking about how stupid you are to present this information, and why did you say it that way, and this is not the way I communicate, and you end up alienating your audience. And if you don't do these kind of testing, you never know that. Conducting the interview. Don't test multiple messages at the same time, test a single message to ensure maximum concentration. Interviews of moderators are culturally sensitive and have good social skills. I found more often than not that if you're doing interviews, women are better than men for conducting interviews, because both men and women like talking to women. Women don't always like talking to men, or they get intimidated by them. Men get competitive with other men. Emphasize that there's no right or wrong answer. Make it clear that you're not testing them, but the material, this is not a right or wrong thing, you're not getting evaluated here. Let them know that you appreciate their helping you improve materials. Always begin with open-ended questions, and so that you're not constraining their outcome. And then pace the interview to maintain attention so people don't get burned out. Sometimes what happens if you make it too repetitive, you get a response set. People say yes, 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 okay, let me out of here. Usability testing is a critical step to taking message development. Message analysis focus on message features, facilitate or hinder audience understanding. And audience analysis, message quality, through listening feedback from members is critically important to making sure that the materials are appropriate and work well. Message analysis data. Readability data are important to interpret. If your target audience reads at the 7th grade level and your readability is at the 10th grade level, you need to simplify material. SAM data can point to specific deficiencies. We talked about the SAM program earlier. Pretest data is helpful to tabulate responses to interview questions. Typical tabulations, interview questions are put in separate columns. Respondent answers are recorded in separate rows. I know this is really simple for you guys, but when I was talking to these people at CDC, they'd never done this before. They didn't know how to do it. So basically looking at percentages so they can figure out what the overall comprehensive level is. The interpretation of pretest data involves looking for patterns both within and across columns. If most respondents provided incorrect responses to a question, then there's trouble in River City, and you need to do something to improve it. If some respondents give wrong responses to most of the questions, you need to know what it is about that respondent or that type of group. And so if everybody's getting it, but there are a few people that don't, maybe they need to be in a separate group. You need to segment. They may need different people. So they may represent a distinct subgroup in your target audience and need further customized messages. Pay special attention to respondents' prompted or unprompted recommendations. That's why I like the interviews. You don't get that with the questionnaires. And so you can really figure out, there may be a lot of things that you're not even thinking about that are being influenced by the messages. Based on the data you collect, you want to try and improve the material. This is basically formative research. So there's no real one way of doing this, but in some cases the decision is easy to make. When more than half of your respondents don't get it, you need to really make major changes. In other cases, you make the decision on a combined consideration of the importance of the wrong response, misunderstanding of dosage information, for example, which might kill somebody, is probably a good thing to think about. And then the number of respondents that are missing the right information. There's a real reluctance. The reason I did this is because there's a real reluctance to change materials once it was developed, because it was expensive, particularly when they're using print. It means they'd have to throw away the old stuff and come up with new stuff. And they just said, I don't want to do that. And say, well, if 50% of the people don't get it, don't keep using it, because it's just going to confuse most of the people. It's not going to achieve your goals. So I wanted them to realize that revision was really important. As general guidelines, materials should be revised if there's any incorrect responses regarding safety information, 5% or more of the respondents replied incorrectly to a comprehension question on a key point, like where do you get a mammogram? There's a high number of wrong or negative responses to cultural acceptability, which means that you're saying it in the wrong way. You may need multiple rounds of pretest and revision to make your product suitable. So even after you refine it, I wouldn't assume that you got it right. You better do that testing again, maybe with a smaller sample, to make sure that the same problems or new problems are not occurring. Participatory user-centered design is a good strategy for guiding. And I don't know if you know about user-centered design, but my friend Linda Newhouse is really like the queen of participatory design. She wrote a really wonderful piece for a special issue of the Electronic Journal of Communication that I edited about 12 years ago, 13 years ago. That I think is a really key piece, and that's open source. So if you put that in Google, it'll come up. You should be able to get it easily. User-centered design basically is when you get the people who you want to use the message to figure out what's the best way of saying that. It's basically realizing that you don't know enough. It's not done nearly enough. And they'll not only tell you how to phrase, but also what channels to use and the best way to deliver it, and how to segment among different groups. And it's basically engaging them in a development process. It's also a great entryway to encouraging these folks who help you design the message to later on help you implement and then help you evaluate, and eventually maybe help you institutionalize. So it's a really great entryway into community participative research. So you start off by getting people to help you design, and then you get them involved throughout the entire process. And Linda's done this a lot. She's done a lot of California statewide health promotion programs for prenatal health and family development and child rearing. And she's worked with a lot of immigrant populations where they designed all kinds of programs that have worked tremendously well. She's won all kinds of awards for that program, those programs. Summary. Message analysis results are relatively easy to determine. Either they got it or they didn't get it. Tabulation is a great way to facilitate interpretation so we can see the percentages of understanding. Whether and how to revise materials is a judgment call involving careful deliberation, but it's important to refine when necessary. Participatory user-centered design can guide revision of materials to really meet user needs. Final note. Although usability testing may stress your already tight budget, you know them, the audience I'm talking to here, and a lot of everybody all saying, "Oh, my boss will never let me do this." You need to demonstrate that this is a cost-effective in the long run, because the products that have gone through rigorous testing will have a much greater chance of reaching and benefiting low literacy populations. In addition, the bad materials are going to have really bad effects, because they're going to turn people off, they're going to alienate them from your organization, or they're going to encourage them to engage in unhealthy behaviors, which is going to have a really negative effect. Instead of helping making things better, you're going to be making things worse. So this is my tag message to these people. Appreciate your work. Thank you very much. Please listen to what I told you. Invite me and my colleagues back again. All right. Well, I'm sorry that I had to provide a really simile, because you guys don't really need this information. But you may end up doing some kinds of training for health promotion people. It's really one of the things that I think that we can do is not only to be interventionists, but we can increase the sophistication of the work that other people do. Yesterday we talked about the Singapore Health Promotion Board, and they do all this health promotion stuff, and not all of it is very good. If we could do, if some of you could do training for those people like I'm doing for the CDC, that would be really great. I feel so clean, so good about doing that, because I know that by helping them, I'm helping the entire nation, particularly of vulnerable populations. And that the work they're going to do is going to have more mileage and be better done. So, think about ways that you can be facilitators to others. Because oftentimes, you won't get involved in some of the nitty-gritty, small campaign designs. But if you can help them become more sophisticated as an advisor and as a consultant, it also will open up doors for you later on when they're thinking about new and bigger campaigns to engage you as an evaluator, as a researcher, and to utilize your expertise. And I end up doing a lot of I call it mop-up work for agencies that do campaigns that don't work very well. Because they realize that they made a mistake somewhere and they want me to figure out what it is. And so I come in and I do evaluation of their product, and then I help them to revise and refine and do a better job. I think that's really nice work if you can get it.
My general impression of the health promotion board that actually they work very hard and then they are pretty keen to help people, but just that sometimes you just feel like, okay, either they are not aware of these issues, or they don't have enough training, they just don't have exposure to this kind of information.
And it's the same thing with CDC and the public health departments in the U.S. They're all good people there because they want to help people.
It's not like they are so mean that they will only use fewer people to scale people, but maybe that's like the only strategy.
But maybe that's all they know.
Right, and then they feel that's okay, in the past it worked, so then they will feel very hesitant to change the campaign approach, because that just means that they move from the comfort zone to an unknown area, and then they don't know how effective that would be. So sometimes that's a challenge.
That's why I love the opportunity to educate these folks.
Right.
And they need continuing education, they need support. And basically I've had good results. Right now, two of my colleagues, one of my former doctoral students and one of the associate professors in my department are getting ready to go to Atlanta to do some training programs. My former doctoral student, Lindsay Hughes, who works for the Walter Reed Medical Center. She does health promotion campaigns, and she's been doing campaigns all over the world on HIV and other health issues. Is going to be talking about building community partnerships. And so I'm really excited about this. This is the first time I've sent her to do training. She's very dynamic, she's very experienced. And then my colleague, Xiaotran Xiao, who's an associate professor, and he works with me on lots of campaigns. He's also out of Annenberg. He was one of Marty's students, and also Joe Capella. And he does all kinds of messaging. He's going to do a message testing seminar for people at CDC. And it's really great to do that because you can have such a powerful influence. So I would say we can find out ways of doing that. If you can't do it for the the major national program, you may be able to do it for smaller community-based health promotion programs, and also for local hospitals and clinics. Maybe a good place to start would be at NU Hospital, NUH. I'll bet they do all kinds of campaigns. They probably have a health education department, and usually it's somebody who's a nurse who has almost no background at all in health education or communication, and been assigned to do it, and very beleaguered and doesn't know what to do and scared, and to do what's always been done, and they could use a little advice and help. Any questions? You've been so quiet with me, I can't get a word out of you.
And the more I'm learning, I'm thinking that what should I do? Like you were asking me a question last time, like what methodology I would like to use or I should use. Even from the religious perspective, I quit smoking 7 years earlier, and then I asked my dad, see, there is a saying that if you follow one order of prophet, so you can ask the Muslim community that, see, I'm following this order. I'm always wearing skull cap, or I'm not cutting my hair, or whatever it is. So I said, okay, see, I quit smoking, you should quit smoking. But my dad said, no, I couldn't help it. This is the way, in our community, people use a lot of aluminum-made cooking utensils, where they cook rice, curries, all these things. Even they boil water in aluminum-made pot, and for they think that if they boil it, and it is purified because the germs already dead. But it's not like that. The practice is different.
Right, because they're getting the residue from the aluminum.
Right.
It probably is killing the germs, but it's not. It's encouraging more residue.
Yeah, a lot of aluminum contaminated water, all these things. So much more chemical. So I don't know, it's a good learning process for me. Sometimes it works. I mean, I couldn't change that. I've been living with my aunt for a few years. I couldn't change their behaviors. Like when I shared all this information with them in the dining table, they might change the plates, but they don't change the utensils, all these things. I always see the things from my community perspective and culture. And how could I share this experience with my community?
It sounds like some of the things I was saying at the very beginning, when I was talking about the theory about how hard it is to change health behaviors. That this is the way it's always been done.
Right.
This is, nobody even questions whether this is good or bad. It's just assumed
Right.
that this is the right way. And so if you say this is the wrong way, you're basically saying my whole history of understanding and my culture and everybody else is wrong. And I can't accept that, so obviously you're wrong.
Yeah, I am a misfit. Seems like that. How could you do that?
And you're the kid.
Yeah.
So what you need to do is you need to kind of get some support. You need to find a couple of other people, maybe who are even more credible and experienced than you, to believe what you're saying. And then it's not just you, it's you and them.
I mean, there should be health awareness in our communities. It should start from the families or education institute, I don't know where to. Even in our societies, one of the major area of work to reproductive health, especially for the girls, reproductive health education, there is a lot to do over there. But yeah, there should be an information sharing space. Especially it will start from the family. If I'm gonna ask my mom that, okay, I will buy you new utensils, but the thing is that they are not familiar with all these different designs of steel-made utensils. They are familiar with all these aluminum-made utensils.
If you bought them some steel pots, would they use them?
I don't think they would use it.
What if you threw away their old ones?
That would be rebellious.
You'd be in big trouble.
Yeah. Even like this culture, like a culture of smoking, especially I could ask some of my friends, see, you have your kids, you should quit smoking. And then I quit smoking, so I could ask you. But they say, dear, this is the only thing I could escape all my anxiety and stress, all these things. I mean, these are all lame excuses. I said, see, I don't want to pay a lot of bill at the end of my life. I don't have ability to pay medical bills. So the reason I quit smoking is quite simple. But I don't want to pay a lot of medical bills. But it didn't really work.
Well, there's a tendency for people to be more interested in short-term outcomes. Long-term outcomes rewards are not so great. There's what's the name of this theory? It's called something temporal. I'll think of it later. But there's a theory that basically says if you can tell people there are things that they'll benefit from right now, it's much more influential than telling them they won't have to pay bills 20 years from now. They don't worry about 20 years from now. So if you could say that if you stop smoking, you won't cough, or you'll have more wind, or you'll have sweeter smelling breath, or whatever it is, or you won't have to pay money for the tobacco. That'll save you money right now. That will be more persuasive than the long term. But the thing about the tobacco is that it's not just stopping it. There's a physiological addiction, and there's a psychological addiction that to give that up is very hard to do. You'll have to find some substitute, and that's why the nicotine gum has been used, as a way of kind of weaning people off it, and that's why support groups are often very helpful of helping people quit. Some people have a more difficult time than others. Did you have a hard time when you quit?
Not really. There was another inspiration because I was been working in a research team, and the team leader was my friend's mom. And she used to say to me that you couldn't be a spiritual man. I said, why? You still smoke. I mean, she didn't like because my friend used to smoke and his dad smoked. I mean, her husband smoked. So three of us always sometimes quit the training and take a French leave or 5 minutes leave and start smoking. And she really hated it. So whenever, I mean, she liked me very much. So I said, okay, I can quit smoking. Don't worry. Give me sometimes like 3 months. And later when I met her after one vacation, she was so happy that I quit smoking.
Because then, you had social support. This, is like, moves us from the individual theory
Right.
to the social theory.
Right.
So it's not just you wanting to quit or be changing you, but you have somebody else who's encouraging you and helping you.
Right. I mean, I quit smoking when I moved to Thailand, but the thing is that I was kind of social smoker. Like my friend is smoking and he's asking, oh, hey, you want to get a smoke? Okay, let's go. During the break of the classes or sometimes. So it's not much I'm familiar with. But again, it was like 3 or 4 cigarettes a day when I'm hanging around with my friends, a buddy or teachers who smokes. Anyway, that was an inspiration from her that I have taken it seriously that okay, I will quit smoking.
But I have a feeling that you are not highly addicted to cigarettes. Both I quit smoking and my wife quit smoking many years ago, back when we first met, 42, 43 years ago, a long time. Back when I was only about 3 years old.
Child marriage.
And I quit smoking. I didn't really have a hard time. I had a cold at the time. And I didn't have a lot of money, and I didn't really want to pay for it, so I just quit smoking. But she had a very difficult time, and even though she really wanted to, she continued to smoke for a long time because I think she had a greater addiction to the tobacco, to the nicotine than I did, and I really had to help her and encourage her. And I did a lot of things that treated her, please quit smoking. I used to hide her cigarettes. I throw them away.
Yeah.
She'd get mad at me. But eventually she quit smoking. But I think she had to kind of get that support and work through it. And perhaps your father may need more help to quit smoking. It may not be as easy for him. He's obviously been smoking for a much longer time than you. And so but there's good evidence that even people who are highly addicted to tobacco can quit if they're given the support. Social support has been found to be really important.
Right. Social support is really important.
But also there may be things like, there are patches that provide nicotine, and there's nicotine gum. There's a lot of different things that people can use, different strategies. So that it's not just, willpower.
Right. They need some kind of support in between.
Right. I think that, if you think about it from the theories that we talked about before, you were trying to originally kind of using the individual theory of, encouraging him, giving him information, basically a health belief model. Now we're talking about maybe providing social support, moving into kind of the social theory of making change. But there may be some structural things you can do too. Maybe there'll be some rules that no smoking is allowed in the house. There's good evidence now that secondhand smoke is very dangerous to family members, particularly children. And so, not smoking is not only something for damaging you, but you may be damaging your children, so you maybe don't want to smoke when there are children nearby. Would that something they'd be willing to do?
That's why I tried like kind of emotional involvement or like if some of my friends, they become parent, mom or dad. So I used to tell them, see, you couldn't smoke now. You're gonna kiss your child, or okay, you're smoking around. Your child will see it. So it's your responsibility. That don't really work for the man, especially for my dad. He didn't really listen to me. He said, okay, see, I have been smoking over my whole life. It doesn't really affect me. It's like,
Does he have a cough?
he had a lot of problems. I mean, around.
Most
70.
smokers have like a smoker's cough in the morning, they wake up and
Doesn't matter. I mean, it's a kind of individualistic, more or less, men. It's kind of patriarchal. I don't know how to say behavior like a society that they think that okay, this is my right. They don't think other way that this is harmful for the family members, especially.
Do the women in your family smoke?
No. In our South Asian culture and practice, I'm from a Muslim family background. They don't smoke usually, especially middle class. But lower class, in the lower class family, women smoke because they work in the field. It depends which community they belong to.
Because the work I do in China, the men smoke a lot, but the women don't smoke because it's not culturally appropriate.
Right. In our culture, same.
And because of that, you see a big difference in the incidence of lung cancer between men and women in China. And I'll bet it's the same thing in your culture too.
They have a lot of bronchitis problem, and I don't know, nowadays number of gallbladder stone increases, and they have some other problem like most of the beverages, even the fish, they put formalin to keep it fresh or vegetables, so they are having a lot of chemicals, and now they have GMO products, all these things. So I mean, there are a lot of reasons they are paying a lot of bill to the private and government medical sector. I mean, every family have a big budget. Every year they have a big budget. They are paying bills to the doctors or for medical treatment purpose, but they don't see it. The problem is they don't see it. I have been urging my parents, my siblings that see, cut off your medical bill, and it's really easy. You can do it. Anyway.
It sounds like you need to come up with a different strategy.
Right. For me, I can do with my small limited income because I don't have much medical bill. That's my
I wonder if
strength.
there are some other people besides you who might be more influential with your father. Who are the people that he looks to and respects and listens to?
Maybe his friends or something.
Well, he is the most senior person in the family. I don't know who. I mean, he lives mostly the countryside. We have a farmhouse, large farmhouse. So if he lives with the family, I have a niece. I mean, maybe it's another reason that if he's gonna move to the city and stay with our family, but he sometimes do like once a month, or he gonna stay together with the family permanently. It could work.
You know, I wonder if you could do kind of a social network analysis of who he communicates with and who's the influential people in his life. It may not be something about in the family, maybe somebody else. Maybe a friend, maybe a colleague, maybe other people who influence him. You maybe want to think about that, because if you can enlist some of those people,
Grandchildren, maybe grandchildren.
Yeah, maybe grandchildren. She started stalking. Maybe she could ask, okay, you should quit smoking, otherwise I won't allow you to enter this house. It might work. Yeah, it might
well,
work.
in the U.S. they did a lot of education to children in schools about smoking, and they really scared the kids, and little kids would come home and say, "Mommy, Daddy, please don't smoke. I don't want you to die." And they'd be crying. and the parents, okay, all right, let me think about it, And so I think that did help. But I think it was multiple messages from a variety of different sources. There was like the Surgeon General's warning. There were, media messages. There were regulations that smoking was not allowed. I mean, and I think that if you can provide kind of a range of different messages, including yours, but I think your message alone is probably not strong enough. It needs to be reinforced by a variety of different sources and channels over time.
Yeah, it could be. But the reality is that a country like Bangladesh, I'm from Bangladesh, as I told you. I don't know what about India. It's mostly similar. People, there is no social norms and rules that smoking in public place is a kind of unsocial activity. I mean, you need to get a permission, and so they think that that's their right. And you can find the rest of the cigarette in every corner of the street. People don't mind. They throw any kind of leftover things on the street easily. They don't have really cleaning habits, healthy habits. They didn't grow through the society. Maybe random urbanization and then a lot of things. Economic polarization made them in this situation, put them in this situation. But there should be a starting from somewhere. Because of smoking cigarette, it's a good amount of budget they are paying every month regularly, and it's adding injury to their health also.
No, I agree. In fact, the World Health Organization and the CDC says tobacco use is the single most influential factor that influences death and morbidity in the world. And if we could reduce or eliminate smoking, it would save millions of lives. It's a huge, huge thing.
But I could influence a couple of my teachers who were professor and senior teachers that I said, see, you should quit smoking. So they quit smoking.
Are there any public campaigns, like media campaigns about quitting smoking, not smoking?
In Bangladesh?
Yes.
Yeah, they have a lot of campaigns. The public health department have campaigns, but there are corporates like tobacco companies, British American tobacco companies. They provide a lot of money. They provide youngsters to do concerts, all these America look-alike or Bangladesh look-alike competitions, all these things. They put a lot of money. So they have all these fascinating skips.
That's one of the problems in China too. The Chinese government owns tobacco companies. So they make a lot of money selling tobacco products. So as you know, they work with the Ministry of Health, and they really would like to get people to stop smoking. But other economic ministries are not very keen on that idea because it's a major product and source of income.
Yes, in India, the alcohol is supplied by the government. So I cannot understand. They have some campaigns about binge drinking, and then they're selling alcohol through they're the main source of alcohol.
They have all
the Tasmac shops. And then I don't understand what the point is, because that's a big source of income, and they don't want to change that. They in fact are increasing the number of such shops.
What they need to do is to find ways of kind of shifting over their business interests to other